We're taking this, 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 we're taking with a pinch of salt.
Hello, everybody. My name is Andreshko Burnett, and you're listening to A Pinch of Salt, a new ARIA podcast series dedicated to asking our incredible guests tough clinical questions and looking for common sense, clinically relevant answers. Hopefully, we'll be successful in asking the questions that we would all like to ask at the ERA Congress, but most of us don't have the guts to do it in front of an auditorium full of our peers. It is an honor and a privilege to have as our guest today, Dr. Swapnil Hiremath. Dr. Hiremath had the courage to tackle one of the most difficult and, might I say, frustrating fields, or perhaps even swamps, of nephrology. That is the subject of what was once called contrast-induced nephropathy and is now called contrast-associated AKI, which is what we'll be discussing today with him. Dr. Hiremath is one of the main authors of the recent Canadian guidelines on this subject. Swapnil, welcome to A Pinch of Salt. How are you today?
I'm good. Thank you again for the wonderful introduction, as well as I'm honored to be here. It's a topic that I love to pontificate on, so I'm looking forward to this discussion.
So a bit by choice and a bit by coincidence, you are the actual very first guest of this new ERA podcast series. How do you feel about that?
That is somewhat unnerving, but I'm hoping this is going to be a great series of podcasts. I'm really looking forward to what you come up with after this.
Yeah, you've been involved with a lot of podcasts, and I think we share the opinion that this is an important way to share information. Maybe we should say before we start with the question that this is an informal discussion among colleagues, and that all your thoughts or opinions are not legally binding, nor should you be legally liable for them, just so we get that elephant out of the room and so we can relax. Are you ready for the first question?
Go ahead, shoot.
Okay, so does contrast-induced nephropathy, which means nephropathy or AKI caused by contrast, which now is not so definite anymore, which is why it's called contrast-associated AKI, is contrast-induced nephropathy in the setting of intravenous contrast application, particularly in planned radiological examination like a planned CT, even an entity that exists in a clinically meaningful way?
The short answer is very likely no, or probably no. But I can give the longer answer for those who are interested. And you're saying what you said about this being a frustrating field is extremely true. So, any paper that you read on contrast nephropathy or contrast-associated AKI, it often starts with the sentence saying contrast-induced nephropathy is the third most common cause of AKI. And that drives me nuts. If you track that source of the citation, it goes back to 1983. There was a paper from Susan Hu from Harvard looking at the causes of ARF. At that time, they called it acute renal failure in hospitalized patients, and it was 129 hospitalized patients, of whom 16 received contrast. Right. So on the basis of 16 people who probably had contrast nephropathy in 1983 in the hospital setting, in 2023, 4 decades later, we still say contrast is the third most common cause of AKI. And I don't blame my radiology colleagues, right? They read this and they say, oh my God, we are doing something bad. We should try to reduce it. So it's partly our fault that we have elevated it. And this may have been true in 1983, but there are a few factors to consider. In 1983, they did not have GFR measurements. So these may have been patients with who knows what level of kidney function. They did not have CKD staging. There was no awareness that contrast could cause AKI, right? Because this was one of the first seminal papers. And at that time, they used high osmolar contrast dye. And this is with no control group, right? So the last part is important. We'll come to that later. So this is high osmolar contrast dye. About 20 years later, in the late 90s, a lot of data came out. The low osmolar contrast dye came out, and they cause a much lower risk of contrast causing any kind of kidney damage in any setting. And that's what we use now. So the risk is much lower with the modern, either low osmolar or iso-osmolar contrast dye that I used. Secondly, with GFR and with CKD staging and all that, the awareness that this is potentially a problem has gone up, right? So we are way more judicious about how we use contrast, and you could argue that we have gone the other way, right? We hardly use contrast, and we perhaps underuse contrast in CKD patients where you lose valuable information. But most importantly, what has happened in the last 2 decades is that there have been controlled studies. So what's the missing piece here is that, and this happens even today, I have a consult, my fellow or my resident goes and sees the patient has AKI, and they look back in the history and they see a CT scan and they say, aha, the patient got a CT scan, the AKI is because it's such a red flag, right? It's a smoking gun that everyone sees and says, this is why. Uh, but what we often miss is that the patient who gets a contrast CT scan, there is a reason why they get it, right? Sometimes someone has come in with abdominal pain, they have got sepsis, suspected sepsis, they get a CT scan. Maybe it's the sepsis that is causing the AKI, and the contrast is just a friendly bystander. Uh, the other setting is in patients who, in the cardiology, right? Someone comes in with a cardiogenic shock, an MI. Do you think it's the MI and the shock that is going to cause AKI versus, the contrast angiography that was done? In fact, you look at the one of the most popular scores for, contrast nephropathy, so-called the Mehran score from Colombia. They have this, right? If the patient is on IABP or has cardiogenic shock, they claim that contrast nephropathy, risk is high. But that, I think, is ridiculous. What that actually shows is that it's ischemic ATN that is going to happen, right? If you have got cardiogenic shock, history of heart failure, use of an IABP, the hypotension is causing renal hypoperfusion and ATN. It's not contrast that you're picking up, you're just picking up ATN. So the controlled studies that have been done in the last decade, I would say, Jennifer McDonald from Mayo and Davenport from Michigan and many other groups, right? But they were some of the first ones. They did propensity score matching. They said, hey, let's look at a good control group. And they show that, these patients who are undergoing these procedures do have a high risk of AKI, whether they get contrast or not. And this has brought down the risk. This has increased our understanding that the true risk is very low. In fact, if you look at a GFR more than 30, there is, I can confidently say with intravenous CT scans, intravenous contrast, that is CT scans, the risk is probably not there at all, right? I don't worry. Locally, we don't worry at all. With a GFR of less than 30, there are a few caveats. And those caveats are that, so the Davenport study does show a small risk, but they had 200 patients compared to 6,000 patients overall, which tells you what is going on, is that in patients with a GFR of less than 30, we are so reluctant to give contrast that it is hard to have a robust estimate of what is the risk. To be honest, I have not seen a true contrast AKI where I was sure that there was nothing else going on, even with a GFR of less than 30. But we hardly give contrast in patients with a GFR of less than 30, right? So I can say, okay, I'm willing to admit that there may be a very small risk of contrast AKI in those with a GFR of less than 30, like fewer nephrons. It's biologically plausible. And what happens is the control group in these kind of studies, they are often over represented by these high-risk patients, because if I have a high-risk patient, I'm not going to give them contrast. So, even with propensity score matching, there is going to be some selection bias. These patients are going to be in the control group. So that's why the risk may be there in that group. But that doesn't mean you should not give contrast, right? Because again, I don't know what's your experience, Andresh, but mine is that with true contrast AKI, where, I see the patient, there is nothing else going on, they got contrast, they got oliguria AKI, they recover, they mostly get better. So yes, it's a nuisance. They are in the hospital for a few more days, and sometimes they need dialysis or not, but they often get better. So, if you're giving contrast, even with someone with a GFR of less than 20, if there is a true indication, then, we should give the contrast. It's a reversible condition. And the risk is so low that all we say, even with the GFR of less than 30, is that make a conscious decision, right? Don't give contrast just to get pretty pictures. Give contrast because clinically there is a need. If clinically there is a need to give contrast, one should give it. So I don't think, from that point of view, especially, the people who get most upset about this is emergency physicians, because I don't know how it is in Europe, but in North America, often they will say, oh, you need a creatinine before you get a contrast, which I think is ridiculous. You've got a patient with shock, with sepsis, forget about creatinine, just do the scan.
Exactly.
Yeah, you're suspecting aortic aneurysm, don't bother to get a creatinine. So from that perspective, critically ill emergency, yeah, if they claim that it doesn't exist, I'm completely fine with that, except for a tiny minority where you should think a little bit. It probably is not an entity.
I completely agree. I was so glad that what you did with the Canadian guidelines, I read that and I thought finally somebody's talking about this in a measured way, I would say. I mean, it's okay to be cautious in medicine. I would agree with that, but maybe at some point we'll have to recognize that we might have made a mistake by calling this a huge issue, which wouldn't be wrong. People can change their mind. And as you have said, I also have not seen a pure contrast nephropathy from intravenous contrast for a CT scan, even in patients with EGFR below 30. And now, if I'm slightly brazen, and I hope that you don't mind that, and that the audience doesn't mind that at all. So, given the current data, we probably think that this is not a very clinically meaningful entity. First. Second of all, we generally think it's reversible, probably even completely reversible. Third of all, the therapy that we have, the prophylactic therapy that we have, various methods of, giving fluids, we don't know if they even work. And fourthly, as you've shown as you've talked about in other podcasts, even if we don't prevent the small spike in creatinine, we might not be missing anything. People might not even have a worse prognosis because of this spike of creatinine. So I think if you showed this evidence to somebody who's outside of the field, more objective, a physicist or whoever, I think they'll probably say, listen, I don't think you need to worry about this.
Exactly right. And this is the thing we faced when we were putting the guidelines together, right? So some of us were saying, hey, it does exist, so we should be trying to prevent it. But then we stepped back and said, hey, prophylactic measures mostly don't work. The hydration, bicarbonate, N-acetylcysteine, what have you. And now we mostly use low osmolar or isoosmolar, which are same. So it's not that by identifying these patients we are going to change, right? We are going to do some intervention to reduce that risk. It doesn't exist. So why even bother to identify patients and to triage them or what have you? You're absolutely right about that. The bump in creatinine. So there's a really nice paper. There was the PRESERVE trial which looked at bicarbonate N-acetylcysteine versus control. And in a sub-study, they looked at biomarkers. Chirag Parikh and his group from Yale looked at biomarkers. And they looked at the patients who had this bump in creatinine in the PRESERVE trial, and they measured NGAL and KIM1 and those kidney injury biomarkers. And they saw that there was no association, right? So these patients who had bumps in creatinines had no markers of kidney injury. So that leads us to suspect that what is happening with many of these bumps in creatinine is that you're picking up some hemodynamics, maybe volume changes, some pre-renal factors or what have you, and not really true AKI, which is clinically meaningful. So you're not picking up, you're just creating a nuisance for yourself rather than picking up something actionable. And we, in fact, what we did is in the guidelines, we said don't bother to check a creatinine afterwards. Because what will happen is that you will pick up many of these bumps, and then that creates a lot of friction in the system. Oh, send this patient to get a lab check done. Should we admit them again, or should we keep them in the hospital longer? Most of which doesn't matter. So why do you want to pick up these clinically not important bumps in creatinine, where some centers do have these quality measures, right? They make you measure it. We said don't bother. If the patient has got symptoms, if they've got oliguria, they get short of breath, sure, go ahead and do that, which you should do anyways. But don't bother measuring creatinine because you're creating work for yourself with no benefit to the patient.
Exactly. I also like the idea of the innocent bystander, because this almost sounds like that a bit distasteful joke about data and statistics, where you can say that birthdays are very bad for your health because the more that you have them, the shorter the life expectancy is, right? So it almost sounds something like that. But the problem that I see is that this is not only a nuisance for us, but this might be very dangerous for the patients themselves, because what I see from where I work is that people get rejected because their OGFR is perhaps 28. and they get rejected after waiting for 3 or 4 months to get the CT scan, which is usually for something important like a lesion or something that might be a tumor, something that might be malignant. And then they get rejected after 4 months. Then they have to find their doctor. They have to figure this out, possibly find an alternative scan, which would be an MRI, which is even more difficult to get. So it's not just a nuisance. It's possibly something that is actually dangerous for the patient, because late diagnostics can be lethal. So how do we, like you said, the radiologists picked up on this and they're really cooperative and they really, started working on this. But now, do we need to talk to them? Do we need to, really discuss it on a local level and say, please, let's stop doing this? Because in your guidelines, you were very, I think it was very well to point out that you shouldn't reject somebody just because of the GFR, right?
Exactly. So the worst thing you can do is to have a non-diagnostic scan. So what happens is they say, sure, you ask for a contrast-enhanced scan, the patient goes there, and someone, the technician or the radiologist on the spot says, oh, GFR is 28, don't give contrast, let's do a plain CT. So the patient gets the radiation, and you get they can't say, oh, are there metastases? I cannot say that. So you end up, or they get rejected. Of course, the scan doesn't even happen. So either ways, you get something that is unhelpful, right? And this is the Glenn Chertow had that paper on therapeutic nihilism in CKD patients where he called renalism. He was talking about low rates of coronary angiography, but this is even more applicable to CT scans. Our patients are often more likely to die of cancer. Cancer rates are higher in CKD patients, for various factors, or coronary artery disease or other vascular disease. And all these things need diagnosis requiring some contrast, right? You often need that. And our patients have a lower rate for all these things. So yes, it is a huge problem. We need to work on that. Again, we are mostly talking of intravenous, but if I can talk a little bit about arterial contrast as well, the same applies there, where perhaps you could argue, okay, the risk is higher, but the benefit is even higher. When this came up and we had some interventional radiologists, they looked at me as in, why are you even asking this question? I'm doing therapeutic procedures. If someone's bleeding, if they have a blockage, you want to fix it, what choice do you have? You cannot say do an ultrasound or do an MRI. There is no choice. You need to have that iodinated contrast go in. Yes, you can use lower amounts, etc., etc. So there are many therapeutic procedures. You miss the diagnosis, but you also miss therapeutic procedures in CKD patients because of this unnecessary hindrance. What we did is we met with our radiologists locally. Before these guidelines, we have been doing this for a while. It's been like 2012, I think, was the first. 2011, 2012 was the first time we discussed this, and it took a lot of meetings, right? Because the issue with contrast is that it may be an oncologist who orders the scan, it's the radiologist who performs it, and if something bad happens, it's the nephrologist who comes in and says, oh, you bad guys, you did a contrast, right?
Yeah,
So
exactly.
so this makes it difficult. There are multiple specialties involved, so you cannot say on your own behalf saying do contrast. They are not going to do it if you just declare, hey, I'm not going to blame you or anything like that. You need to sit down at the table. We had emergency physicians as well involved here because they were really annoyed at this hindrance, and we met several times saying, hey, this is it, we are not going to say this, please go ahead and do it, please go ahead and do it. And it takes some time for the culture to change. Even now, we make sure we educate our fellows saying, don't call it contrast nephropathy, right? Because it goes back, right? It's like, oh, the radiologist or someone sees this and they feel bad, right? They are, I mean, no disrespect to radiologists, but they are not clinicians. They don't see patients, and they just see, hey, maybe I did something bad by giving the contrast. They are not refusing scans out of a pleasure of refusing scans. They really do not want to cause harm. So it took several meetings. We met with them several times over those first few years. Get everyone together in the room. We met with our nephrologist team saying, hey, please, let's, this is for our own patients. Let's go ahead and give contrast. Stop doing this. Even now, occasionally it comes up, but now it's far less frequent. We meet once a year just to make sure everything is okay. But that has really streamlined our process of getting things done locally. But when we had this Canadian guidelines put together, a lot of other people were saying it's a big problem in our place. Can you come and talk to my nephrology team, because they are still in that different place. So it's fine to have a guideline, but I think if you're trying to implement it, there is no other solution than getting together with all your colleagues, all the stakeholders, and talking to everyone and saying, hey, even the technicians, right? Because that's what been ingrained in their brain, and they will keep flagging it. And who knows what radiologist is there.
Yeah.
So we need to make sure everyone, your fellows, your nurses, dialysis nurses, educators, everyone on the team to understand that this is a non-issue, and we should be giving more contrast so that our patients get the benefit.
Yeah, thank you very much for sharing this experience, because that's the exact same thing I was thinking. We need to sit down with our own radiologists. This is a thing that you can only solve locally. And as you know, well, from your probably personal experience, it's not the if part, if you need to do it, but it's the how part. Yeah. So just sending an email won't do it, right? So it's the how part that's important. And I'm really glad that you shared how you were able to do it. And I'm sure that we'll probably need to do something very similar. So just before the end, I'll just like to ask you one more controversial thing, if you don't mind, and that's metformin. Now, metformin has been dragged into the story also as an innocent bystander, I believe. And what you've written in the guidelines is definitely very true. And that is that you should think about what you should do with metformin when the GFR is below 30, or when you have a patient with AKI, right? Which is very reasonable. But the silly question that I would like to ask you: are patients who have GFR below 30 or AKI even patients who should be getting metformin in any case? Because they probably are not patients that should be getting metformin in any case. So is it maybe a fair statement to say that we could tell diabetologists and our fellow nephrologists, just use metformin as it's supposed to be used, and let's not bother the radiologist and the patient with it? Is that a fair statement to say?
Exactly right. There are several layers to this, right? It's not as simple as we think it is when you go to the implementation side. The problem, of course, is that the package insert for metformin, and I'm not sure what it is in Europe, but I'm pretty sure it's the same, still says that, oh, if you're on metformin, don't give contrast, right? And that's a medico-legal thing that from some cases of lactic acidosis that happened, several decades ago. What probably happened in that setting is that the patient developed AKI from either from contrast or from whatever else, maybe it was ATN, and the metformin was not stopped, so it was continued. And the patient developed metformin-associated lactic acidosis, which is a real entity. We know that. It's pretty ghastly when that happens, especially, it was probably shock. There is a 30, 40, 50% fatality rate depending on how we are able to manage it. So that's what led to all this, thing. But what happens as a result is, even in a patient with a GFR of 50, if they're on metformin, it's like, oh, we cannot give contrast. It gets canceled at the last minute. The patient is there, someone sees the metformin, and then they say, oh, you have to stop it for 2 days and all that, right? So that is completely ridiculous, because the risk of getting AKI with a GFR of 45, 50, what have you, is practically zero. Let's say it is zero with CT scans. So why should metformin doesn't increase the risk of AKI. It doesn't increase the risk of lactic acidosis if you're on a stable dose and they don't go into shock or hypoperfusion or what have you, right? So that was the main reason, saying for the vast majority, it doesn't matter. And the other problem we faced is that who does what, right? If we say in the guideline, oh, you should do this, it's often the radiologist, and the radiologist will say, I don't feel comfortable stopping the metformin, because then maybe they need more insulin, maybe they need an SGLT2 inhibitor or a GLP-1 RA, or an increase in something of their dose. If their sugar goes up, then who is responsible? So rather than do anything like that, they just cancel the procedure, right? So that was the problem we faced, and that I'm sure that happens, right? So things get canceled, or because no one is comfortable making that decision, and it may be the oncologist who ordered the scan, and the diabetes is being managed by a diabetologist or their family doctor or who knows what. So this creates a lot of mess in this situation. So this is why we ended up with a guideline we did, saying if the GFR is less than 30, and again, to be honest, I use metformin off label sometimes, even with a GFR of less than 30. I think there was a really nice paper in NDT showing you can use a lower dose, but that's, let's assume we are not doing that with those kind of really high risk patients. That's the only situation where metformin should not be given, and it should not be given because of the AKI and the contrast stuff. It should not be given because it should not be given. So that's sort of the guideline we ended up with, saying taking the responsibility away from the the radiologist who is on the spot, saying, pushing it back to, saying, hey, your patient's GFR is 30, less than 30, please reconsider using metformin, and leaving it at that, rather than the whole AKI business. With the contrast, the risk is so low, it's zero or close to zero. Metformin is a non-issue. It's all the
Yeah.
medical legal pain, right, at that package insert, which has caused so much of a nuisance over the last 2 decades.
Yes, exactly. I completely agree with you. So, Swapnil, thank you very much for joining us today and being willing to share your vast knowledge and clinical experience, and also real life, everyday logistical experience on how to tackle this issue. And for our audience, thank you for listening to the very first episode of A Pinch of Salt. Stay in contact with us on Instagram and X at ERA Kidney, and on Facebook and LinkedIn at European Renal Association. Tell us what you think. We'd like to know. And check out our other podcasts. You wouldn't want to miss them. Stay safe, stay happy, and do what you do best. Be an amazing doctor.